Hello and welcome, everybody. So if you want to know how the use of FHIR is advancing in German hospitals, you found the right session. My name is Wedekind. I'm an e-health architect with Gematik in Germany, and Gematik is comparable to NICTIS in the Netherlands or the ONC in the US. And I believe that having cool technology solutions in your toolbox is great. And if you match them with problems of real people, relevant problems, then your solutions can really fly. The problem that I want to talk to you about today is that of disconnected care scenarios. So I guess we are all aware of the heterogeneity of today's IT landscapes in hospitals, maybe illustrated by the abundance of abbreviations flying around. You have HIS, LIS, KISS, PACS, and many more. And all of these specialist systems are good at what they've been built for, and usually less apt to be used in integrated care scenarios. And today I want to mention some of the reasons for that and mainly talk about how we at Gematik enable integrated care scenarios and help to realize them. And Gematik is not primarily a software vendor, although we also build software. Like the e-prescription solution for Germany we introduced last DevDays, in which will be available basically end of this month. We primarily develop standards together with all major stakeholders in the German healthcare sector to enable vendors to build both safe and interoperable solutions. So let me explain to you how we're doing that, starting with this simple example here, which is about using vital signs from the bedside in therapy decisions. So on the left, a nurse takes vital signs on paper or on device, and then this data needs to be stored for medical documentation purposes in another system. So it needs to be transmitted to some kind of health record or where the patient's medical history is stored. And then on the far right, the medical professionals that want to use this data for medical decisions need to derive all of the available data needed for that into and draw them into yet another system. And all of these special systems are not very well connected. In fact, most of these special systems are not connected in German hospitals, and if they are, the cost of integration is very high. So you can differentiate maybe two different approaches to integration. So like on the left, the data lake approach, where specialist systems pump data into a data lake, and eventually another system gets data out of the data lake and makes some sense of it, or uses it for integrated care scenarios. And then on the right, slightly different approach, which I call direct integration, where specialist systems use their existing API to directly integrate with one another, or they are maybe wrapped into building blocks of a data processing pipeline. And in both approaches, some specialist systems might already speak FHIR, but each in their own dialect. And this is what I call the FHIR integration issue. I found a nice quote on the Asymmetric website that puts it nicely. We think of FHIR as a common language, but it's really like a common alphabet. And it would be cool to have building blocks available that can be used in a wide range of integration scenarios, entities with the same meaning. So that you minimize maybe the implementation effort to support a wide range of integration scenarios. And in the IsiK project, we started building such a language and started with a basic set of data objects that you can see on the simplified information model on the left. It has data object like the patient that is used in many different scenarios, or coverage, which is used in particularly valuable scenarios for the hospital, like billing. And to ensure that these objects are actually used, legislators in Germany decided to make them mandatory from a certain point in time, and the Gematik defines the mandatory confirmation procedure to check that primary IT systems and hospitals actually implement these data objects correctly. And we want to go beyond pure data objects and support integrated care scenarios directly. And we have an issue here because we cannot possibly standardize all foreseeable integration scenarios in hospitals. Yeah, so for one thing, you cannot look into the future, and also the medical expertise needed for that obviously lies with the medical professionals and their organizations, and not so much with the gematik. But we also want to enable interoperability or innovation on integrated care scenarios instead of preventing it through overstandardization. So the sweet spot for us was here to standardize small and typical interactions, like we call them, between often used data objects. So we specify both data objects that are used in the same meaning in different scenarios, and also interactions on them. And we put them into modules so that a stepwise implementation of IsiK, the IsiK project, is possible for vendors and hospitals. So we start with a basic set of data objects, like on the left, and their interactions, and we have modules for vital signs, or later for medication scenarios. So coming back to the example from the start, you can see here on the right sample interactions that can be used in the steps that we've seen in the example. So, for example, at the bedside, an interaction to get the current encounter for a patient can be used, or when you want to draw vital signs into the data, into the health record or medical documentation system, you could use different interactions to filter for particular types of vital signs or vital signs in a given time range. And on the bottom, you might get with an interaction or vital signs, for example, other observations for a given encounter. And we are developing this specification, which, by the way, is of course available in Simplifier, in close collaboration with organizations of vendors, providers, payers, patients, and major FHIR initiatives in Germany. So to achieve real interoperability, to make it very transparent from the start. And we also support and moderate the adoption of IsiK in close collaboration with the previously mentioned organizations through various formats. So we do developer workshops, which enable vendors to get up to speed very quickly. So we invite developers to ask their questions so that we can get them over the first hurdles very quickly and start a conversation. And then we also fund showcases. So hospitals can apply for funding to pilot IsiK in their organization. And I have put here some examples of clinics, both big and mid-sized clinics in Germany that implement IsiK in different scenarios, like transplant patient care, transition management, or inpatient nursing, and a number and a lot more different scenarios. Okay, and we plan to have connector funds as well for regular sync on the state of the IsiK implementation between different vendors. And IsiK has even more potential to advance e-health in Germany, at least. And because the main goal for gematik actually is to provide a secure and interoperable platform for health data exchange to the German healthcare sector, and we call it the telematic infrastructure. And IsiK advances the modernization and evolution of the telematic infrastructure with its hands-on interop know-how. And in return, IsiK benefits then from access to the services of telematic infrastructure, like maybe federated ID or inter-hospital data exchange. And as a side effect or as one aspect of this, by introducing REST and FHIR resources, for example, to hospital scenarios, we also open the space for integrating mobile apps that can be prescribed by the doctor or can be used in hospital integrated care scenarios or beyond, like aftercare solutions. So what we learned in the first year of IsiK, because IsiK is also a project that will be running for the next couple of years. What we learned in this first year is that key to adoption of interop like IsiK is compatibility with like major FHIR interoperability initiatives, governmental organizations and organizations of providers, payers, and researchers all need to be on board because involvement and understanding from the start on results in engagement. That's what we've experienced. Yeah, so we involved key players in the German healthcare sector, and that resulted in this common understanding. Yeah? And we quickly got beyond politics, which helps to get to a technical level to discuss and work and develop together the standards for IsiK.
Anna, I think we lost audio for a second.
So I can maybe, sorry for being late, this is Marco. So I can maybe finalize this saying that, yeah, for us, the bottom line is collaboration driven by a concrete value to get FHIR. This also had a nice. Okay. Yes.
Sorry, I'm trying to get back audio. Would you like just to wrap it up yourself, or would you like me to try and get the audio back? I'm sorry for this.
I would just go ahead, Anna. Thanks.
Side effect, if you will, that we got both organizations for mesomedical professional organizations on board that provided the problem understanding and explained to us the needs of hospitals and what would be a sensible integrated care scenario. And this combined with the solution expertise of the vendor organizations involved. Yeah? And that resulted in a very robust standardization process and very good collaboration with fast feedback cycles. And also we experienced that it's so important to drive interop value, to drive interop efforts by value, yeah, because interop is about at least two parties that now need to come together, that maybe have built special systems before and now want to engage in an integrated care scenario. And this value needs to be very tangible, yeah, because usually also interop of efforts are longer running efforts, and people don't pay vendors for interop per se, but for the value it enables. Yeah? So you always need to be able to explain the concrete value that you enable with this, let's say, technical effort to achieve interoperability. So we think the bottom line for us is collaboration driven by concrete value will get FHIR to the next level.
Okay, everybody, this is Melinda from HL7, and we have Marco with us. We're going to open it up for questions right now. You can either post your questions in the Q&A box in Whova, or you can unmute yourself and ask them live. Oh, we have a question in Whova. Would you like me to read it to you, Marco, or can you see that?
That would be nice, yeah. Mm-hmm.
Okay. Could you please talk a bit about the general adoption of FHIR in Germany and the attitude of future adoption?
Mm-hmm. So what we experience is that FHIR is all over the place, so people are talking about it, which is a first step, but still hospitals are a bit reluctant to implement FHIR because, as I said, in the end, they still need to justify their investments into standardization, and they have invested a lot in IHE infrastructure in the past few years, or maybe 10 or 20 years. And now switching to new technology per se doesn't provide additional value. Yeah? So we need to combine that with, for example, enablement of mobile use cases, especially for hospitals. This is quite a new area. So big hospitals and university clinics, they are investing in bigger projects as pilots, but mid-sized or small hospitals are not there yet. Some of them even use Word as their hospital information system, and use a lot of paper still. So digitalization is not very advanced in some hospitals in Germany, or on many of them. So yeah, that's at least my perspective at the moment.
Okay, I don't see any more questions in the Q&A, but we'll give it a minute if anybody wants to unmute themselves, or if you're having trouble unmute yourself, you can also raise your hand and I will help.
Hello?
Yep, Amin, we can hear you.
Oh, great, thanks. Thanks for the presentation. You know, I like your comparison of FHIR to Alphabet, because that's how I feel as well. So my question would be, because you know, as you said, it's an alphabet. Do you think it's a bit naive to say that, you know, let's say I work like by myself in you know, within my organization, I'm going to just adopt FHIR, and then I'm going to hope that everybody can just, you know, integrate with me like immediately when there's when the need for integration rises up, and there will be no problem and it will be great. Do you think that's really naive to think like that?
Well, it's true and false. I mean, of course, as with every integration technology, it's there to enable integration. Yeah, and it's just a matter of effort. Yeah, and scope. If integration is feasible or viable in the long run. So I mean, if you just have a common alphabet, of course you can talk to each other, and eventually, if you, for example, in your own organization can agree on a common standard, on a common language, then integration in your organization or between these parties that have agreed to this common language is easy, yeah, as always, but scaling that to external parties will become harder, because you need to talk to them, and then the actual the actual pain point in interoperability that I'm trying to address here in my talk as well is showing up more strongly, that you need to talk to people. And you need to find a common language in discussions. And FHIR is an enabler there. That's for sure. It helps a lot. And still, these conversations need to take place to find this common language. It means not just related to FHIR as an interop standard or a syntactical or standard, but also reaches out to other standards that are related, like SNOMED and LOINC and others for semantic interoperability. So. Yeah, it's both true and false. Did you?
All right, thanks.
Did that answer your question?
Yeah, just to make sure I understood. So basically, I can say that you know, FHIR would be like a, as you said, like basically a helper, like a starting line, like a baseline, let's call it a baseline,
yeah,
which everybody can understand, and then you still have to communicate with, you know, external parties so that you can interoperate. It's not going to be free. It's like maybe it gives you like 60% of the work done, not more than that. I mean, roughly. I mean, doesn't have to be
depending on your kind of project. Yeah, like with an implementation language like Java, for example, of course you can build interoperable Java solutions spanning multiple hospitals or communicating between different parties. But then again, you need to define a common language on both ends of the communication. And I see it like that with FHIR as well. So it's kind of an implementation language to frame or to implement solutions in e-health or healthcare interoperability. And the next layer, so to say, on top of this technical interoperability layer is a common language that you need to agree on between humans.
Yeah, thank you so much for that.
And we are at time. So if you did not get your question answered, please post it in the Whova Q&A box and Marco can follow up with you after the session. Marco, thank you so much for that unique perspective. Thank you for everyone joining us today. Please make sure to rate your session and hope to see you later on tonight for our finale.